This is a relay project.
The Discourse starts right now with Cheryl Oates and Erica Barudis.
Welcome back to The Discourse. Last week, the provincial government dropped the first budget of its latest mandate, and one of its communications focuses was healthcare.
And so today on the show, we're going to take a closer look at the policies and funding commitments the UCP has made. And then we'll also welcome the president of the Alberta Medical Association, Dr. Paul Parks. Before we do that, if you find that with all of these healthcare changes, all the information you're seeing, and you feel like, you just don't really get it, thankfully, our friends over at Pocket Lobbyist have broken it down into newsletters, webinars, and briefing notes. So if you want to learn more and get brought up to speed of exactly what all of these changes mean for you and our healthcare system, go to pocketlobbyist.com to get your membership today.
So let's start with policy, because we did our budget special last week and we talked overall about budget and touched just a little bit on healthcare. But there has been a lot of policy, and now we have a blueprint of what the government intends to do with the healthcare system moving forward. So it's worth just diving deep into the policy commitments and the funding commitments that the government has made so far, and what they mean for those working on the front lines, and also what they mean for Albertans. So let's start with policy, because in November, Premier Smith announced sweeping changes to Alberta's healthcare system, resulting in a major overhaul. Let's hear from her on that.
Starting today, we're creating an integrated provincial healthcare delivery system that concentrates on 4 priority areas: primary care, acute care, continuing care, and mental health and addiction. We believe that by creating specialized organizations within one provincial system, we will enable each organization to look after one area of healthcare only and avoid the scattered and uncoordinated approach of the more rigid, centralized structure that exists now.
Okay, so we've gone back. I think it's important for our listeners to also realize, like, AHS, when they came back under, the super model or super board, the intention originally with AHS was to be that acute care service provider, to operate in hospitals. Obviously, what we've seen is its roles and responsibilities grow over the last few decades. And I think you may disagree, but I'm going to say we should all agree that it almost became a cog in the wheel. And so I think what the government is trying to do is remove that cog from, the Alberta Health Services, and then all of the service providers, and put AHS back into being that service provider. So you're going to see these 4 pillars, or they're called organizations. I'm sure that name will change, but acute care, primary care, long-term, and mental health. Now, I know what you're going to say, Cheryl. You're like, oh, well, by putting them each into their own silo, they're not going to talk to each other. All of these things.
Is that my voice?
That's your voice when I'm kind of mocking you. You did an impression of me, I think, too, last week. Anyways, that's not what you really sound like. That's just my Cheryl voice for right now. I think that I did ask that same question. I was like, well, how do they not silo if there's not something? There's an integration council that is actually going to ensure, with a lot of bureaucrats in there, which you love, making sure that those groups are also talking to each other. So this new structure, I think by what you see right now, you could jump to conclusions about them operating in these silos. But I think the government's also done a good job to layer over that checks and balances of this integration council.
I think it's worth, for those who maybe haven't lived in Alberta over the past decades or haven't paid attention to healthcare reform, how many times this has been tried. Because back to 1994, we have seen conservative governments work to shuffle the deck chairs on the Titanic over and over and over again to distract from crisis in the healthcare system. If we look back to 1994, that's the beginning of all of this. We saw Ralph Klein bring in 17 new regional boards, new regional health authorities. 2004, only 10 years later, we decide 17 boards cost too much. Never saw that coming. And that they're fighting over resources. They're fighting over power. Let's just slash it down to 9. Then fast forward 2008, we say, you know what, actually 9 boards is too much. Let's amalgamate this all into one health authority, which is how AHS was born. And this was at the time thought, we're going to save costs on administration. We're going to have no infighting. We're going to be able to control what people say and what they say about the system. We all remember, how the cookie gate that happened after AHS was formed and Stephen Duckett was put as the first CEO of the organization. If you haven't seen it, go to YouTube. I use this clip on almost every political communications class that I teach, where Stephen Duckett is walking down the street, mobbed by reporters who are asking him questions about why there is queue jumping, why there is a crisis in the ERs, and he literally eats a cookie the entire walk and tells them, "I'm not talking to you right now. I'm eating my cookie." If you haven't seen it, it is very easily findable on YouTube. Not surprisingly, he was ousted from that job shortly after that, and we saw more changeover in who was running the system and who was at the top of it. And then when we saw Prentice come in 2015, and as a pre-election throw, he said, "You know what we need to do? We need regional health authorities. We need regional boards again," and pitched the idea of bringing in a whole bunch of new regional boards again. Luckily, the NDP was elected, and the NDP decided that the only change they would make was bringing back a board to AHS rather than having it run by an administrator. And there was peace in terms of healthcare structure until 2022. So all through the NDP, no major changes to how AHS was structured, no additional chaos into what was already a system working to recover. And then in 2022, Danielle Smith comes in. She says, "You know what? You know whose fault COVID was? AHS, just far too slow to respond. We're going to blow it all up and start all over again." All this to say, we've seen it tried. It doesn't work. We've tried multiple models, and I don't see how a system in crisis right now, having more chaos added back into it, is going to solve any of the problems that we're currently facing.
I love that you say, luckily, the NDP were elected. Like
Obviously.
Nothing happened and that everything was solved under, we still had wait time issues. We still saw the beginning of family doctors being a crisis. We saw all of these things. Like, I think what we can say, regardless, since 94 and probably before, there's something that's not working with our healthcare system. And regardless of the NDP, PCs, UCP, there's got to be some changes. And I do appreciate forward-thinking ideas. Who knows if this one's going to stick and be the one that knocks it out of the park?
That gives me a ton of confidence.
Well, you could have asked me. You could have asked me this on the same of them. Like, none of us have seen this be put into action. I do like that they have that integrated council to do the checks and balances for each of these areas. I do like that service providers and the playing field of who can operate these and bid is leveled out so that it's more competitive. It's not a monopoly of AHS. So I think that there is some things that they're definitely getting right and that I'm looking forward to seeing. I mean, the anomaly is a little bit on the mental health pillar, and we'll see a lot of that, I think, come out by the government. But the other 3 organizations, I think, are very similar to how they operated, just who they're operated and how they're run and where they are within the field. And they're all kind of along as a service provider because AHS wasn't meant to do all the things it was doing. And I think that's where I would point to the other efforts, not going back to what was the root cause and what was AHS's original intent. And maybe we should have them stick with that. So I think this is a step in the right direction, but I'm not going to be like, this is amazing because we haven't seen it come to fruition. I said last week on our budget podcast, I'd like to see the government show where reforming AHS, where that is showing efficiencies in the system. I know it's not going to happen right away. I don't believe in throwing money at the problem. And I'm sure we'll get into that when Dr. Parks joins us as well. So what does this look like going forward? And, I think it is showing that the government is actually doing something and making bold moves. And I'm continuing to be optimistic about where this is headed.
And I just don't think this is the right focus in terms of the problems that we're dealing with in healthcare. We've just seen a budget. There's no one can say the government hasn't laid out its plan. Like, yes, this reform on this scale will take time, but for Albertans that need access to the healthcare system right now, for a province that needs more capacity, we can't wait for 4 new organizations to be formed. I would have liked to see in this budget money that added capacity to healthcare across the province. Instead, there's less capacity. I would have liked to seen the intention for more doctors to come to the city, more frontline workers. Instead, we see that budget actually being cut over time. So yes, we can all, put our hopes and dreams in the healthcare reform and the creating for organizations, hoping that they will run more efficiently. But so far, history has not led us to believe that that should be successful. And all of the other pieces for a healthcare system in crisis can't wait any longer. And maybe that's a good segue to looking at some of the stuff that, like we said, we're going to have Paul Parks, the head of the AMA, on a little bit later. And doctors themselves have been sounding the alarm over this because they've been looking for a new funding model. We'll hear from Danielle Smith, but first, let's just hear the campaign that the AMA has been running, where frontline physicians have been sort of posting stuff very regularly. For a one-day blitz, they did it, and they continue to post, talking about the impact of lack of funding for their personal practices.
I get no locum help. There is no way that a solo family practice is viable under these conditions.
I am incredibly concerned about the number of residents who are choosing not to practice comprehensive primary care in the community.
Due to the shortage of family docs in the province, I have said yes to too many folks who could not find a family doctor, and now I am completely overwhelmed.
I know many people who are planning to leave Alberta. So speak up for good healthcare for everybody.
I get what they're trying to do here. I get the grassroots style campaign of having them do the iPhone selfie, all of those things. The thing is, you can clearly see people read. This was right after Christmas, right after the family docs got an additional $257 million to help what I would call a bailout from mismanagement during COVID. I'm sure my dad's gonna love that one. Because he's a physician and likes to tell me where I can be more thinking like a physician as opposed to the political lens. But I do think, though, that's $257 million that they didn't even bat an eye or appreciate. It was like, okay, well, that's not enough. And so I think that I saw that campaign and I was like, ooh, that's distasteful to me. Again, if it would have been in November, very different than I think coming out in January after this large lump sum that the government gave them.
Family physicians are the bedrock of the primary care system. They and their teams are the first and best resort for anyone dealing with chronic conditions or needing an initial diagnosis. Doctors, nurses, paramedics, and other medical professionals want to spend more time with the people that they are treating and less time on paperwork. But the existing system puts so many burdens on them. So we're going to change this situation for the better as quickly and as efficiently as we can. We are in discussions with the Alberta Medical Association on a new family physician payment model to support comprehensive care and ensure that doctors are seeing more patients.
On the whole, I think that messaging sounds great, which is typical of Danielle Smith, who is an incredible communicator. But what I think the AMA is waiting for, and I look forward to hearing Dr. Parks talk about this, is actually implementing this formula. Because right now, there are doctors across Alberta who are waiting to sign leases, who are waiting to make decisions about retirement, who are students deciding whether to specialize. And every day that the government waits to actually implement a new compensation formula is a day that those doctors are potentially not practicing in Alberta. And at a time we're at crisis. There are people across the province that don't have a doctor. I don't understand why the province can't move forward with this.
I want to come back. I'll come back to this, but I do want to highlight something that you said when we were talking about the 4 pillars. And I promise it'll dovetail back into where we're at today. But okay. I think when you were like, there's a healthcare crisis and you're talking about this, well, those 4 pillars actually address all of those. We talk about
when, though?
We talk about wait times. We talk about family doctors. So if you're looking at the recruitment and retention of family doctors and what our primary care looks like, you've got an organization that's focused on that. When you're looking at wait times or emergency services or getting people out of the hospital and into longer term care, you've got 2 organizations to address that. So I think that this model actually does address those crises that we're seeing and the top of mind priorities of what we've talked about. You and I, both parties talked about it last May. It was obviously top of mind, but it always came back to access to a family doctor, a primary care provider, wait times, and emergency services. And these silos actually do help that, along with mental health and addictions. Now, when we're coming to the funding model, There's also a lot of other pieces out there. 18 months ago, the docs got their deal. 1% increase first 3 years with fourth year review. So unlike everyone goes into 4 years for bargaining. So I think one thing is why are they coming back to the table? And I will be sure to ask Dr. Parks that after 18 months, knowing that he was not the president at the time. Secondly, that we also have this additional lump sum from the federal and provincial government. We've seen price increase to healthcare as a whole and to family docs of $6.6 billion in physician compensation this budget. So when you're talking about this negotiation, we've also had a hybrid in the past where doctors could be on a salary versus fee for service. I don't think the doctors themselves know what model they want. And I know they're looking at other jurisdictions and things like that, but I think that to say that we want it now, but we don't know how, I think is also something that we have to consider both for what the government and the AMA should do.
Oh, well, I think some of this is purely political. I think the AMA knows how to leverage that, and I think the UCP is putting themselves in a pretty tough spot. If nothing really has changed since the election in terms of what the top issues are for Albertans. People are worried about affordability, and people are worried about access to the healthcare system. And at a time when people are focused on healthcare and the access to healthcare, no government wants to be in a public fight with physicians. And so the AMA knows that. They have done a really good job of raising the issue and making sure that Albertans understand that without doctors, the system will not get better. And I think the UCP is going to have to continue to listen to their concerns and find ways to work with them, because the political impact of an ongoing fight with doctors is it's a huge hit.
No, I mean, I don't disagree. Politically, that is not a battle you don't want. I mean, it's similar to nurses striking. There's when frontline providers are willing to go to battle. Unfortunately, the government is at a disadvantage for sure, because I think, again, understanding what these people do every single day is important, and that they do have a bargaining chip for sure. However, the one thing I'm going to call you on, Cheryl, is you said it's still a problem. Affordability is still a problem. Healthcare is still a problem. I mean, I didn't sit there in May being you know what, by the beginning of 2024, everyone in Alberta is going to have a family doctor, because there's people that have to go through med school. We need to up that recruitment. Sure. We need to get more people to want to go into family practice as opposed to specialized. I think that's a cultural change as well. What would the NDP do? I know we've got a clip of Rachel Notley's response to the actual budget, but besides throwing a bunch of money at this and thinking that doctors grow on trees, I can't fathom how yeah, you can sit here and criticize the government, but I can't even think of what the NDP would actually do that would be, besides put us in debt and give doctors a bunch of money, which I don't think I've learned that they're the best to manage money. So please shed light on how this would be so much different under an NDP government.
First, the NDP would not have added a whole additional layer of chaos to a system that was in crisis. We know there are some issues that are adding to Albertans' lack of access to the healthcare system. If an NDP government had been elected in 2023, we would have seen the NDP go straight at those issues from day one, rather than, like I said, a political distraction of reorganizing the system while doing absolutely nothing to address access to acute care. Let's build more beds. Let's build more capacity. Before we jump into the blueprint that the government has laid out, which I think goes against a lot of what the NDP would do, let's hear from Rachel Notley, because I think she covers a lot of this in her budget response.
Albertans deserve to know that if they're injured or they get ill, they can get care at a hospital close to them. They deserve to know that if their mom is sick, they can bring her to a family doctor. Instead, Albertans have a government that risked families' help with their ideological plan to contract out lab services to private services, resulting in at least a $97 million public bailout of a private company. Instead, this budget fails to staff up hospitals and health facilities with the very staff who are crucially required. Just to keep up with population growth, let alone the profound shortages our hospitals face, this government would need to plan to hire an additional 2,800 staff in healthcare. Yet, This budget is planning for less than a third of that.
Okay, so this is like political fluff and like, as you used last week, smoke and mirrors. She's like painting sunshines and rainbows of what she could do. She also uses lab services. Like, come on, that one has been reversed. It's been corrected. That was under Kenny. I know that's the same government.
Okay, so
but
let's forget about it.
Well, no, not let's forget about it, but like that course has corrected. If she would have gone after this reform of
After
AHS,
millions of dollars of waste.
Right. But like you're also saying you're going to throw $1 million, billion, whatever dollars. Like all I hear when Rachel Notley talks about that is like, we're going to just throw money at the problem. And that didn't work for you guys in 2015 to 2019. So I don't know why you think it would work now.
So you're right. We didn't win the election in 2019. But Albertans got better healthcare under an NDP government than they would have got had a UCP government or a progressive conservative government been elected. Under this government, in this budget, we see an absolute move away from what the premier has been saying, which is she wants less administration, more money to frontline services. This budget does exactly the opposite by putting more money into the administration and the Ministry of Health and very little increase, far, far below population and inflation into frontline services. It cancels major capital projects. It has no money to add the acute care beds that Alberta needs. This budget is basically saying not only is what we have right now good enough because we refuse to offer spending increases, but it's not going to get any better. They're saying we're not even going to keep up with population and inflation.
It's 4.4% that the budget increased this
overall,
year from last
1.3
year.
to frontline services
to physician compensation, 6.6, which is up $504 million from last year, which is 8.3%. So tell me where that doesn't cover affordability and like inflation and population, because to me that does.
No, I'm not talking about how much money you put into administration. I'm not talking about how much money you put into the reorg. I'm talking about hiring nurses and frontline staff and making sure that we have the capacity in hospitals that we need. None of that is reflected in the budget. And I don't need, like, I'm not talking about meeting a number underneath what the fiscal framework is. I'm talking about keeping up with the number of people that there are in Alberta to provide the healthcare services that they need. This budget doesn't do that in this year, and it certainly doesn't do that in the out years. In fact, over the course of the fiscal plan, it's a massive cut to frontline services.
And I will say, like, one thing I did see is that the years out, I think that there is more, but I do think that we're going to see cost savings come in those other years. Because of efficiencies within the system. So we have to remember that when you look at...
Such a conservative line, though.
Okay, but there's also like things that make me mad are like the $164 million that's going towards training, recruitment, everything for frontline services that isn't getting any traction because that doesn't sound sexy. Or you have like the MAPS that was introduced, and that's the shift of nurse practitioners and what family clinics look like. Like, I think there's a lot of money that went before the budget, Cheryl. There was a lot. There was $250 million to frontline services for compensation.
But that should all be reflected in the budget.
It's not, though, because it came before the budget. It's in last year's budget.
Well, it should show up in last year's budget then. But like year over year increases, if it was spent last year, it should still show up in terms of whether the budget's going up or down this year.
That was like extra money going to offset. I'm sure Dr. Parks will love that I called it bailout. But that went to AMA to the physicians directly into their pockets. It didn't even go to AMA. There's a lot of things I think that the government is actually doing where they're also looking at this as especially primary care, those are businesses. Those are where the family doctors own and they have employees that work for them. They're changing the model. We also had them go through negotiations 18 months ago. So I think you and I could probably talk about this forever, but we might want to bring in our expert to
Let's do it.
to push back on both of us. Well, we're bringing in our expert to hold Cheryl and I both accountable to what we just said. We're pleased to introduce Dr. Paul Parks, the current AMA president, as well as an emergency doc in Medicine Hat. Thank you, Dr. Parks, so much for joining us.
Thanks for having me. It was a bit odd. I was driving up here and I listened to some of your podcasts, so it's like you kept me company on the drive up. So.
Well, Dr. Parks, we're going to jump into a couple of topics today, and I know you'll definitely want to talk about physician compensation and the funding model because that's what you've been focusing a ton of your time on. But maybe we can start with the budget. What was there? What wasn't? Is this level of funding in healthcare sustainable?
The budget itself could be a talk all in itself on the healthcare side. There's some concerns for sure in the sense of that a lot that was announced, like we're trying to dig deep into, there was big pots of money that was announced. So, 475 million for family medicine, for example. But when we look into that, I actually think some of that was PCN money that was already in budgets and 200 million of the stabilization money that we desperately needed to stabilize family practices. I think that was lumped in there. Similar there, in the physician services budget, there was money lumped. There's a bunch of lumps of money, which, we need the money. The system needs some. As to what it's going to go to, the big concerns we have looking at it, trying to figure out where's it going to go. But the bigger thing is we know for a fact it's not going to keep up with population and inflation. And I think it's really important for people to understand on the healthcare side too, if you add 200,000 new people to the system every year, which we've been doing in Alberta, there's inordinate costs there. Plus, there's big costs if they don't have primary care and access to family physicians. Everything's more expensive. But it's not just population and inflation. It's also an aging population, a lot of complex disease. There's a lot of care that's been deferred because of the pandemic, and then technology. So a lot of those components, I don't think were factored into this budget. And we're really concerned that they're, that they put some money, but maybe not enough for the bureaucracy and the reorg, and definitely not enough money for frontline.
Can you maybe explain to our viewers, because you are a member-based organization, who you represent? I know obviously we've talked about family physicians, but who the Alberta Medical Association represents, and then maybe talk a little bit about how that relates to the budget with specialists, family physicians, and the whole scope.
Yeah, so the AMA is a physician organization, of course, and our membership is the numbers around about between 12 and 14,000, varies a little bit. I think we're well over 94% of physicians in Alberta. Don't quote me on the exact numbers because it fluctuates a bit, but the point is the vast majority of physicians in our organization are represented by us because it's a voluntary to be part of the organization. And we are the official representatives to negotiate with government for physician funding related, anything related to physician funding. But also we are at the tables around any big issues in terms of operations system input to give to really try to guide from the front line what some of the expert opinion is. So I'm not sure if that totally captures it, but I think the other part of that is, yes, I think people have been hearing that there's been a big push around physician compensation and discussions on family medicine because it's very critical and a major top priority for our province. But we absolutely also represent the specialists and the different specialties. And we do actually have in the background that's working with government around some really critical pieces on some of the operational and funding pieces for our hospitalists, for example, and some different specialties too. So we represent the whole breadth.
You did mention the negotiations. So I know, and correct me if I'm wrong, but this was before your time when AMA got into the negotiations 18 months ago and went through the collective bargaining to get to where we are. Why is it that the AMA is now coming back to the table or hoping to, because it's usually within every mostly 4 years, but sometimes 3, to revisit that. So what's the strategy and why do you think it's appropriate to bring that back, or if it's a big part of something bigger?
No, that's an excellent question, because that's something sometimes that having to really reframe why is it so critical to discuss family medicine when we're kind of in the middle of a contract that we negotiated. There's two big pieces. One is it's beyond critical access to family medicine specialists and how desperate it is across our province, and how integral access to family medicine is for obviously keeping Albertans well, keeping them so they don't get sick and have to come see me and emerge, but also all the preoperative care, postoperative care, mental health care, they take care of children, all cradle to grave, all of those pieces of the healthcare system. Family medicine is the foundation, and it's truly in crisis. Why wasn't it addressed in the last budget? That is $1 billion question that I wish I'd been at the tables. I know for a fact that at the time, I mean, obviously things in negotiations, not everything can be disclosed, but at the time, it was made very, very clear that in order to really address the issues that everybody could see in family medicine, we needed to develop a new funding model. There needed to be a different way to do this. And that's something that we have since given to the government. We've been pushing and really actually advocating as hard as we can to say, hey, we need this new funding model, which we can discuss more on if it comes up. But at the time, it was made clear by government that there wasn't enough time to do it. It wasn't able to incorporate that in there. And at the time, there was a very express with the last government promise that MAPS was going to do it by spring of 2023. It was going to be a special process. It was going to do a lot of the work up front, and it was going to create that funding model and really address the crisis in family medicine. And now we're almost a year later, and that didn't happen. And a part of that, obviously, is a change in leadership and a change in government. Lots of reasons. But in that year and that time that's gone, it's truly become beyond critical for access for our Albertans. But in the meantime, BC created a new model and leaped ahead of us. Manitoba did the same. Saskatchewan did the same, and Nova Scotia, and now Ontario's right in the process. They just happen to have different times when they were negotiating, but they are miles ahead of us now in terms of family medicine, like in the range of paying their family physicians $100,000 to $170,000 a year more to run their small businesses. That's not to go in their pocket. That's to run their small businesses. Then add inflation, add the cost of living and that all Albertans know about, and how we have to pay the staff and everything. All those things have come together to make it so that in Alberta, it's truly not viable to do comprehensive family medicine as we sit right now. So, and here's the thing, and I know you do ask this, Erica, government can sit till year 4. They can say, hey, it is in our agreement. We can wait till year 4 to address family medicine. I'll be as blunt as I can be, and I've said it to the minister and the premier, you won't have anything to build on by that time. They'll leave, that foundation will dissolve, it'll blow up acute care. They'll all come see me and emerge and have to be hospitalized, and it'll cost 10-fold to 100-fold more. We can't wait. That's a bit of a capsule summary of why it's beyond critical and why we're talking at the highest levels and really trying to make the public understand how important it is.
And where do you see it sitting now, Dr. Parks? Because I've seen some of your public commentary. You feel like you've made progress, but a lot of it is still like putting good faith in the government that they're going to follow through.
Yeah, I mean, and that was the last promise directly after the budget with the minister. I said, so we have a model that Alberta Health we've agreed in the big components. The model, in a nutshell, moving away from just direct fee for service, where you have to have the thing that drives Albertans crazy is you're only allowed one problem per visit, because if you have a family physician, because this model was set up that you basically fee for service, you had to do everything in front of the doctor. The new model has a panel payments, it has rate payments, and it has time payments, and this is what other provinces have done. We've agreed on those components. We've agreed on the big pieces. We're trying to get to the nuts and bolts and the final dollar pieces, which is always the last piece. But we are so close that we desperately need the government to say, yes, we're jumping in, we're going to do it. And the minister promised that she will move on the model as soon as possible, and that it is going to be competitive with our Western provinces. But here's the thing: is in the meantime, you can't pay your lease with promises. You can't pay your staff. You can't. There are everyday doctors telling me in the smaller clinics that they're discussing: are they going to renew their leases? Are they going to keep their offices open? And so we need that hope. That right now in Alberta, family medicine specialists are the lowest paid physicians in the entire province, and they are now currently the lowest paid physicians and specialists in all of Western Canada. And their practice is just not viable, and they're such a critical, essential piece of our healthcare system that we just cannot afford it. The forest is on fire, and that budget looked like, well, maybe we'll put some money away and save down the road, and we'll put the forest fire out in a year or two. Like, that's how desperate things are. We need them to call in the firefighters and get that model for us right now. And I mean, I hope that the minister and premier are going to, announce that, yes, we're go live April 1 or as soon as we possibly can. That's what we're looking for right now.
So just so I'm clear, and then I have a question. The model has been agreed on by AMA and like obviously your members, as well as the government on what that structure looks like, which sounds like it's a little bit of a mixture to address fee for service, the desire for salary, et cetera. I do want to ask about, because I will say, I know how hard family physicians work. And I do think, like, even when I worked for Premier Redford in 2013, when we had negotiations, maybe 2012, there was a critical gap between, or a significant gap between the price that family physicians, which at the time they were still making, I think, over 20% more than any other province, but that there was a significant gap between them and specialists. So as the president of AMA, is there not a way to actually review the entire model so that like the fiscal accountability of how much is going towards that can be redirected to frontline services? And I guess what I'm saying, as opposed to throw more money at the whole problem, is there ways to look at, again, like I remember ophthalmology is the best example with cataract surgery. It goes from 45 minutes to 7 minutes. The fee for service is the same. Is there not ways that you can work with the government to look at what the specialists are making and actually redirect to close the gap on family physicians? Because I am 100% in support of that. I just don't think, again, throwing more money, if there is money that can be reallocated within the current budget or the current system.
Yeah. So yes. So what you're talking about in terms of income equity between specialists and in the province is something our organization's been looking at in a big way, in many ways, and actually have done a lot of work to find out, why are there differences in pay, and are some of them, are there some just and reasonable reasons? But even when we do that work, there is some discrepancy. And so we have to do work on that income equity. And that's actually part of what this funding model will help us do as well. I do understand there's something that is probably important to realize in the last government, that another piece that made this so critical is when Minister Shandro, right before they tore up the contract, not only did they tear it up, which is unprecedented and never happened, it has really made it almost impossible to recruit into this province for the last while until we've started to change that course. But they also made some very big unilateral changes to family medicine that actually amounted to about a 20-30% pay cut to family medicine right before the pandemic. They took away some of the comprehensive care codes. They did some things that I would even consider a bit crazy, in the sense of they don't let family medicine physicians look at and do a comprehensive review of their medicines and their care plan. They took that away, but pharmacists can do it and bill it to Alberta Health right now, where we have a very bizarre scenario now where it's big, the pharmacists are doing this in total isolation and separated from the family physicians. When you have one, it's a bunch of things change. So yes, we need to do the work of bringing that disparity back and the equity around the different specialties. That has to be kind of done in a very nuanced way, because there's market factors, there's different reasons why the pays are different. But what I'll say, and I've said this to the minister and to the premier, is we're willing to do that work as a profession. But we cannot do it until we shore up family medicine first. It's kind of like saying, you know what, let's do a year's work of seeing if we can find some money in the budget that's already there. And in that year, we'll have no family physicians left to give it to. That's the crisis we're looking at right now. And so we need investment up front to stabilize them, so that then, yes, there is some work that the AMA has been working hard on on the income equity piece, and is positioned to be able to look at some of how we can do that in a just and fair way that doesn't really upset access and really impact patient care and our recruitment and retention of all of our specialists, all of our physicians.
Maybe this is a good segue, Dr. Parks, into sort of a higher level question about the state of healthcare in Alberta, because we've seen the campaigns from the AMA talking about a system in crisis, and specifically in family medicine. But I mean, Eric and I have been talking about issues that exist across the healthcare system. So maybe your thoughts on that, and your thoughts as well on the government's announced reorganization of AHS.
Yeah, I kind of hate being the person that's always here saying things are bad, but they are. There are a lot of big fires going on right now, and it's not just family medicine. Family medicine is beyond critical, and that's why we've focused on it the last little bit. But I work in acute care centers. I work in the emergency departments. I see the the entire system where it's not working, and we have some major access block and overcrowding and some really serious issues around what's happening in our acute care system. Like, we actually have some services where, internal medicine and in Edmonton can't recruit, and their funding model has been neglected for more than 10 years. So this government, both the government before and this government inherited it, and now they're on the brink of not being able to provide service and admit sick people to the hospitals, capping. There are a lot of pieces that are just that just keep on dominoing and getting worse. And one of the pieces that I've been saying publicly and to the minister too is that's why it's so critical that we can kind of shore up the family medicine piece and the funding model imminently and as fast as we can, so we can address and look at some of the emerge overcrowding, the access to surgical times, our cancer care. There are issues in lab that we're trying to fix. There are a lot of big pieces. And then to tie all that into the reorg, we are very concerned, and we have said this openly to government and Alberta Health in many ways, that having 4 orgs is really going to complicate this. It's going to really complicate. I'll give you a concrete example. Every day I work in emerge, and we have inpatients that can't be admitted. They're called emerge inpatients because they can't go up to the floor. Probably the biggest reason that is because we're overflowing. We don't have enough capacity in our acute care systems, but we have patients that are called alternative level of care patients they've had their care in the hospital, they're better, but they need to get out into continuing care. In some of our facilities, that's a third of our hospitals, like 35%. With this reorg, what happens when there's a tension between the acute care system is drowning, the acute care org is drowning because they need to get these ALC patients out into continuing care, but a continuing care is operated and run by somebody else that is got their own issues, and they don't want to take those patients. And then I know that they plugged in above an integration council, but I've asked specifically again and again, is that operational? Like, is the minister really going to actually look at these tensions and say, oh, you have to do this, you have to do it's a really confusing and distressing setup when you have 4 pillars and you don't know what they're holding up and who's operationally controlling over top of them. And I really worry for how patients are going to transition between those organizations. I just did a night shift in emerge. I saw a third of my patients overnight probably had mental health and addictions issues. They're coming to see me in an acute care org. How do we connect them into the mental health and addictions org? How do we transition them? There are so many pieces in here that the system is so fragile and struggling right now to add multiple layers of reorganization of different organizations. And then to add, there'll have to be extra layers of bureaucracy. The last thing I want to see is that, the government's talking about cutting out middle management in AHS and whether or not that is we're lean enough or not. I wouldn't comment, but I would comment. It wouldn't be a good strategy if they just cut those out, fire them, and then put them over into Alberta Health. And then they're actually just more bureaucracy over in Alberta Health. And they're even further removed from any operational clinical decision-making or any kind of perspective on the acute care system. That would be a very bad outcome, but that looks like what's in the works right now.
You're talking about all the issues. You're talking about surgical wait times, emergency care, like getting people out of acute and into long-term. And then you said how it ties into the reorg. And as you were saying those things, I just thought, this is the exact reason why a reorg is needed. And you almost are looking at it as the reorg and addressing these issues as two different things operating at the same time as opposed to cohesively. So can you maybe explain that a little bit? It just, to me was like more of your opinion than maybe some actual stats. So I'd love to dig into that.
Yeah, well, so I was able to listen to a bit of your guys' earlier part, and I should say for the record, I was in a back room when Duckett had his cookie gate. I was there. I was one of the few physicians that had to go testify at a public inquiry. And the reason I bring that up is so back then, 2007, 9, 10, the pressures that we were having, a lot of them had to do with ALC. A lot of them were very similar. A lot of them had to do with significant emerge overcrowding, and we needed to get ALC patients out of there. So what happened in that time, we started getting things better because we had objective benchmarks. We had government saying, yes, we're going to do this. Yes, we're going to see patients in 4 hours and get them out. We're going to try to transparently show what's happening. If they need to be admitted, we're going to do it within eight hours. Yes, we didn't hit those benchmarks, but we had them and we were gradually improving on them. And what actually happened in the AHS world, as a criticism that I know from this government, and maybe it's fair, is it got bigger and bigger and metastasized because AHS started to see, oh, hey, you know what? Why is AHS doing anything related to continuing care and acute and long-term care? It's because they were seeing, well, that was the answer and the solution to their acute care issues. And they started to try to create solutions and have some control over that sphere, over that area. Now, again, you could have an entire discussion and a long show about did they do it right, or are there the ways to improve that? And obviously where we're at right now with our access block, things should improve. But carving out that piece completely from the acute care org and having acute care org have no control or influence over how the other three orgs work when they're so integrated. I keep saying ALCs, but our mental health patients, they're overflowing in our hospitals. Like, it is beyond I've not seen in 25 years that the number of sick mental health and addiction patients and the capacity issues. How do you manage those tensions if you create 4 silos and then don't have an obvious, really controlling operational control over top of them? So I do want to say we're trying to do as best as we can from an AMA organization to work at a working table with the ADMs who have been tasked to create these orgs and trying to give them some advice. But I'm not looking at them as separate pieces, and I don't think anyone in the actual acute care system and healthcare system, that are seeing these roadblocks and bottlenecks. I think what we're actually saying is we need better integration. If the idea was we weren't doing transitions into long-term care and into mental health care out in the community as well as we should have, then the solution is how do we improve that organization and that integration and that flow? And I just worry that the way these silos are without the operational control clearly defined above it, we'll run into more troubles. What do I do at midnight in a busy emerge department when another org completely separate doesn't want to help me out?
And I think it's worth noting, like, we hear a lot of criticism, especially when you hear, like, it's a talking point, and I'm going to categorize it as a conservative talking point, to say, like, we need to trim the fat. I know, Erica, you love to say we need to trim the fat. And I think it's worth noting, like, AHS, when you look across Canada, has some of the lowest administrative dollars dedicated to it as a percentage across the country. Like, it's like 2.5% or just over that, which doesn't compare to some other organizations. If you look at the budget, healthcare per capita has gone down over the course of even this fiscal plan. And in terms of the number of beds, there's just no capital allocated to it. So we hear a lot of talking points about how we need to get rid of administration and we need to trim the fat. But I mean, what this budget has is actually, if we're calling it fat, adding more fat to the existing system. Dr. Parks, I wanted to switch topics just a little bit while we have you here, because we recently saw the provincial government announce a policy that would limit access to healthcare for trans youth. And I know we could spend a lot of time talking about the policy itself, but what I wanted to ask you about is, medical professionals in Alberta are self-regulated. They are self-regulated just like lawyers are. And that is because we have decided as a society that those people who are experts are in the best position to set how they deliver care. And we saw the AMA speak out about the government, in this particular announcement, sort of overstepping into that relationship between doctors and patients and overriding the care that doctors could decide to provide to those seeking it. So maybe just a minute on your thoughts on that.
Yeah, a minute is pretty quick on a big topic too. Yeah, no, we did. So it was the sections of pediatrics, children, and adolescents. So one of the things we did was reinforce the fact that we think it should be evidence-based and expert-driven, and went to the experts who do the care within the AMA and asked them. And of course, their positions were informed by national and international consensus on the best evidence. But I think the biggest piece there's so many pieces to this that I would love to talk about, but one of the big, really concerning from the profession is that legislating this type of, getting involved in legislating this is like practicing, medicine without a license and legislating, medical care. And what the biggest concern is Albertans, and we try to reinforce this to the government too, is who's best to provide that advice. It should be having things that legislate where it takes it out of the hands of the professional and the parents and the patient. That's what's happening with this. And I can give you an example if you want to move it out, is that I saw a case a long time ago, anonymized, of a 15-year-old that came in that was, critically ill, obviously very sick. And it became clear to me quick that they were bleeding to death internally from an ectopic pregnancy. So they had a pregnancy in the wrong spot, bleeding to death. And the kicker is they're 15 years old and they're a Jehovah's Witness. Here's the thing. Who's best to decide for that patient if they should get blood or what interventions they should have? It should be done in the scenario of someone. That's why I worked 15 years. That's why that's why all my specialties, we've spent years and years getting the expertise to make the decisions. Are they mature enough? Do they have informed consent? Is it appropriate to bring the parents in? Is it appropriate to make these decisions collectively together? And then in some scenarios, we bring in another physician and get second opinions. Sometimes we even have to resort to getting, legal opinions in certain things when it's obviously not clear, and when it's not imminent life and death, like that example I give you. But the point being is we're very concerned as a profession, and I think most Albertans, and I do actually think this government ideologically, most governments would think that it should be the profession, it should be the patient when they're mature enough to make it, and or their alternative decision makers when they're not, that are the people that are the best to decide that. So you only gave me a minute, so I could talk a lot more on that, because there are big issues on that piece, and it's very concerning. And one of the things I would say, I don't want to always be negative. So the ad that we want to bring more experts into Alberta, and we want to have better care for trans patients in Alberta. That's an absolute benefit, and I'm glad Premier Smith said that. But here's another question. Will those experts want to come into Alberta and work in an environment where they can't use their medical judgment, where they can't work and interact with the patients and or their family if it's appropriate, but they have to do it based on legislation? That's not going to be an appetizing environment. So we're very concerned about that.
Well, I appreciate you, giving the context of a different example. I do think that you and I may not agree on this topic, but I do appreciate you again removing it from the policies. And my question was going to be on why the AMA didn't come out and while they were talking about all of the legislation, actually talk about those two policies on the private registry and those specialists. I appreciate your little silver lining there, and then went back a little bit to the negatives and concerns. But if this could, what would you like to see coming out of this? Should it be moving to legislation or the consultation between now and potentially when it's introduced or when it is introduced in the fall, that would make you, feel heard? I know that was some of the pushback prior to the announcement when it came out.
Yeah, well, and I should say, I don't mean to be all negative, because we have a good relationship with the minister. I do, and I'm even communicating with the premier and trying to. So I think what we need absolutely is a collaborative relationship where we can provide our input and we can give our expert input and make sure that this is driven by best practices, by evidence, by the professional and specialty opinion and input. And I do think ultimately, I understand the drive to, be cautious and protect patients, but I would just also stress that in medicine, everything we do has risks, and not doing things has risks. And that's part of us being a profession and specialist, is every day we have to weigh those. And there's also a component too of everything we do has negative side effects and sometimes bad outcomes, and can have serious regrets. And so those are, all those factors have to be taken into balance every time we make decisions and every time we do this. And in especially like my mind, a lot of times it's even very time sensitive, and we have to do it in a very quick, life and limb threatening kind of time sensitive way. So I would really love to have the opportunity to work further with the minister, with the premier, and say, let's make this evidence based and informed by the profession, and let's not have kind of put the government sitting in the medical exam room between the patient and the doctor.
Dr. Parks, we really, really appreciate your time today. We know that you have to get off and get a little bit of sleep before you head into your next shift. So we appreciate you spending so much time with us and sharing your expertise and insight with us.
Thanks, tons, for having me. It was a pleasure. I definitely enjoy your show. So thank you.
Well, thank you for joining this episode known as the Doc Talk. If you live in Edmonton, we have a full page ad in this March-April edition of Edify. So grab it at your newsstand as you're at your local coffee shop.
And we will be back the same time next week. But until then, make sure to like, subscribe, and download the Discourse on YouTube and wherever you get your podcasts.
The Discourse is hosted by Cheryl Oates and Erica Barudis. Follow on Instagram at The Discourse Pod. Subscribe to The Discourse on YouTube and wherever you get your podcasts.